we just learned about central venous pressure, and there's some more terms that I need to teach you. Pulse pressure is the difference between systolic pressure and diastolic. So if we take a typical 120 over 80, the pulse pressure would then be 40. Now, something else that I want to tell you. That mean arterial pressure calculation that I showed you, the 0.4 times systolic plus the 0.6 times diastolic, that's not the only formula out there. So if you're using a different textbook or you take another class, there's another one where it's like 1/3 and 2/3, and there are all sorts of different permutations on how you can do that mean arterial pressure. I just showed you one. So if your professors in the future explain to you another one, don't think that they're telling you a false truth or I taught you incorrectly. There is more than one out there. So this is a little schematic to show you systolic pressure during heart contraction. And then the blood pressure vessels would recoil. There would still be blood inside them, exerting a pressure. That would be diastolic pressure. And then, of course, the next cardiac cycle would be starting. The difference between this peak and valley represents the pulse pressure, which is usually about 40 millimeters of mercury.
Don't forget your story.
Oh yeah. Okay, slight little tangent, but let's make it work, shall we? All right, just so you have an idea of what I'm talking about, since I didn't tell it to the Tuesday class. Just bumping up a little bit ahead, this will be reviewed on Thursday. But you have baroreceptors in your carotid sinuses and aortic arch. These detect the amount of stretch. The vagus nerve will carry action potentials up to the medulla oblongata, and cranial nerve 9, the glossopharyngeal, will carry it up from the carotid sinuses. Those are roughly right about here. Now, have you heard of someone getting carotid massage? Mm-hmm. When do we do that? Well, a physician, a very well-trained one, need to be careful, can put slight pressure on the carotid arteries. Those baroreceptors would detect more pressure. You see, it doesn't have to be from the inside pushing out. It could be from the outside pushing in. They don't have eyes. All they know is we're feeling more pressure. So with more pressure, the baroreceptors will send up more action potentials up to the brain. The medulla oblongata interprets that as, oh my gosh, our blood pressure is skyrocketing, we need to reduce it. Heart, take a break. Reduce chronotropy, reduced inotropy. So the resulting output from the brain is more parasympathetic, less sympathetic. Now back in the old days, banks used to close at 3 o'clock. Want to know why? Part of the reason why was because the men who would work in the banks would wear heavily starched, high buttoned up and ties, right, collars. And that would be a lot of pressure on their vagus nerve by the baroreceptors, and that's a whole day's worth of parasympathetic output. So they would get to the point where, oh, I feel so sleepy and my heart doesn't feel, I gotta go home. So they close up the bank. Isn't that cool? Now, necking and swooning. Someone's necking you, kissing all over your neck. Why do we have images of women swooning when someone's kissing their neck? That's a whole bunch of carotid massage going on there. And that means baroreceptors sending more action potentials up to the brain, and the resulting output is more parasympathetic, less inotropy, right, because it's less sympathetic, and they faint. That's their swooning, right? I feel faint of heart. So that's the reason why. So, you didn't know that, did you? That was my story. Going back to where we were. Oh, right here. All right, factors that affect pulse pressure. Remember, pulse pressure is the difference between systolic pressure and diastolic pressure. So what can affect systolic pressure? What can make it bigger to make a larger pulse pressure, just for an example. More stroke volume. If the heart ejects out more blood, then that means the blood vessels have to stretch even more, and systolic pressure would go up. The recoil would be just the same. There would still be the same amount of blood left in the blood vessel during recoil. Diastolic pressure would not be changed. So larger systolic, subtract from it diastolic, that means pulse pressure would go up. Compliance. Arteries are, the elastic arteries, are more compliant than arterials. If the elastic arteries, and muscular arteries sustain damage, maybe a high cholesterol diet, atherosclerosis. Atherosclerosis can lead to arteriosclerosis, which means calcium deposits. And that means you're going to get, don't say hardening of the arteries. That's not something they really like to say in a clinical setting. You're supposed to say less distensible, less compliant. So the more rigid those arteries are, that means when the heart contracts and ejects the stroke volume, then that means there's less give. And there's more pressure being exerted on that bolus of blood that was ejected. That too can make systolic pressure go up. That's part of the reason why when we're taking someone's blood pressure, we are mindful of both numbers going up. If both of them are going up, that's telling us that the patient is having less and less compliant, less distensible arteries. And their blood pressure is going to be to the point where they have hypertension. As a side note, hypertension, you are pre-hypertensive if you have a blood pressure of 120/80. So that is our, if that was our normal, right? That's no longer our normal. That now is early signs of hypertension. So now we got to work out harder and eat better and lower cholesterol even more to get that number lower, and then not come into a physiology class. Right? Nerissa.
The arterial compliance is going to mean that it doesn't give as much?
Correct. Okay. So
thinking compliant would mean it's
I've got less compliant means
Okay.
pressure goes up.
okay.
Okay, so here's our little analogy. Let's pretend that the class is going to make a circle. We're going to hold hands. And we're going to have, let's say, 20 students holding hands to make this circle. The rest of you are going to be in the middle of the circle. And I'm going to then say, okay, the 20 of us that are making the circle, I want 5 of you to come off of the chain and go inside the circle. The rest of us, the 15, will regroup and hold hands. Can you visualize that there would be now more students in the center of the circle, but our radius has gone down, right? Or circumference, if you want to think of it that way. If I have 5 more students leave the circle and go into the circle, then that means more students pushing us, right? We're going to be like, oh, but we're trying to hold it together. So think of the students in creating the circle of hands, now trying to push back on that volume of students inside the circle. We're not being as compliant. We're not letting go of each other's hands. We're exerting more pressure on those students inside the circle, and they're exerting more pressure on us as well.
So arteries are more or less compliant than
Arteries are less compliant than veins, but their distensibility and compliance can change with time. They can become less distensible, less compliant. And that's what we are really saying when we say someone's arteries are hardening. Okay. Okay, so let's put all of our vocabulary together and try to paint a big picture. What have we learned? We've learned mean arterial pressure is a skewed average, giving more weight to diastolic pressure than systolic pressure. But if we stop and think about this, when we're thinking about Ohm's law, and we rewrite it for flow equals change in pressure over resistance. Mean arterial pressure is this value. That's what we're calculating, the driving force for blood flow. So do you remember when I asked you, if you know these values, could you rearrange this equation? How would we rearrange that equation to solve for P? It'd be flow times R. Okay, so what determines mean arterial pressure? Here's our peripheral resistance. How vasoconstricted are our blood vessels? Flow. What's another term for flow? Cardiac output. What determines cardiac output? Stroke volume and heart rate. So I'm simply rearranging Ohm's law, and then on the left side of the screen, showing you what factors can influence resistance and how we can calculate cardiac output, which is a type of flow. The difference between systolic pressure and diastolic pressure, of course, just to say it again, we use a weighted average of these to calculate mean arterial pressure. But if we take the simple difference between them, that calculates pulse pressure. What can influence pulse pressure? Stroke volume or decreased arterial compliance. If there's decreased arterial compliance, we'll get an increase in pulse pressure. More systolic pressure pushing on the blood inside, less compliant arteries pushing on that blood inside, and that means a greater difference between a greater difference in systolic pressure and diastolic pressure. So down here, I've simply put into an equation form what I've shown you here as a picture. Cardiac output equals flow. Flow is equal to a change in pressure over resistance. TPR stands for total peripheral resistance. Mean arterial pressure is not a true average, slightly skewed for the diastolic pressure. And pulse pressure is the difference between systolic pressure and diastolic pressure. Okay, so as I said in the beginning of class, we have very erratic pressures. We've got systolic, diastolic. And what you're seeing in this picture, that as we go farther away from the heart and these arteries, we see less of a difference between systolic and diastolic pressure. And certainly when we get to an arterial leading to a capillary bed, we're going to see a huge dampening of that systolic, diastolic, erratic pressure changes. That's good because we want it to be more even-keeled before we get to the capillary beds. We wouldn't want them to experience that pulsatile nature. They would be shredded to bits. So, the arterioles are called your resistance vessels, or a pressure reservoir, because they are going to have a dampening effect on the pulse pressures. So, all blood vessels have blood pressure, but the blood pressure drops from the aorta to the vena cava and finally to the right atrium. We have to have this change in pressure in order to get blood to flow. We know that blood will only flow from an area of high pressure to low. We see that there is the greatest change in pressure across the arterioles. They have a thick tunica media. They're going to have a huge dampening effect on that erratic pulsatile nature. At the beginning of a capillary bed, near the arterial end, the pressure is 35 millimeters of mercury. At that point, it doesn't make sense to say systolic or diastolic because the two have fused. Just one pressure. At the venous end of a capillary, it drops down to about 10 millimeters of mercury or so. So the average throughout the capillary pressure is about 17 millimeters of mercury, somewhere in the middle of those two. And then the veins, we're going to see a further drop in pressure all the way through the vena cava to the right atrium. We're going to see that 15 millimeters of mercury drop down to 0 in the right atrium.